Because if you have ever been admitted to a major hospital, you have interacted with Epic, whether you know it or not. Epic was again founded in 1979 by Judith Faulkner. In a basement, sounds familiar as so many other ones, in the basement in Wisconsin with a $70,000 investment and 3 part-time employees. Not a major Silicon Valley launch, but a basement. Now, it wasn't until 1992, 13 years after it was founded, that Epic released its first real electronic medical record product, 13 years before a core product even existed. Now, we're going to jump again, and it wasn't until 2003 that Kaiser Permanente, the nation's largest non-governmental healthcare provider, selected Epic as its core vendor in a deal worth $1.8 billion. So let's look at the dates again. From a basement and an idea in 1979 to mainstream adoption in thousands. That is more than 2 decades just to get to the table. And then hospitals. They actually had to implement it. Massachusetts General Hospital once again spent $1.2 billion in 3 years on this one rollout. This is not an IT implementation. This is a business transformation. That is what the CIO has said. Now, Trinity Health is currently finishing an $800 million Epic implementation. Northwell Health estimates $1.2 billion. University Hospitals in Cleveland has spent $400 million, and that was considered under budget. Now in Norway, we talked about this earlier. 25% of doctors considered quitting after Epic launched. Over 90% called it a threat to patient health in 1 year. In Denmark and Finland, peer-reviewed research found that Epic implementations were still causing serious problems. Not 1, but 5 years later. And then it took another 3 years after to go live. So Epic today now holds the records of over 325 million patients. It controls 42% of the acute care hospital market in the United States. It took 40 years of iteration, failure, rebuilding, and investment. So now we're here today with AI, and here is where we have to be clear-eyed. Researchers at Rutgers found that because there is a lack of representation among AI developers, and because Black and brown patients are underrepresented in medical research, listen closely, those same gaps can carry directly into the AI systems being built. One study found that correcting racial bias in a healthcare algorithm could increase the percentage of Black patients receiving additional care from 17.7% to 46.5%. But that gap is not a glitch. That is decades of inequity baked into the data. So Black women are already 40% more likely to die from breast cancer than white women. Black mothers face more maternal mortality rates that are multiple higher than their white counterparts. Deploying based AI tool is not going to fix this. It may even make it worse. So researchers at Yale published a 2025 framework calling for what should be basic, mandating the inclusion of Black researchers and community members in AI development, repairing audits from anti-Black bias, demanding transparency in how algorithms process race-related data. Those are not radical demands. Those are the minimum. Now, getting unstuck in this moment means understanding that we cannot afford to wait for the technology to get good before we demand that it is also equitable. Those two things have to happen at the same time. We have to have a seat at the table.